So I'd say that it's, and that applies to BRAF as well, that's primarily clinical observation. I mean, the biology changes. That's true for MSI high. I know Dr. Siambor gave a nice talk about MSI high. I mean, we really change somewhat the behavior of the cancer because when you hit biology early, the key is to hit it early. And there are other factors that may explain that, including that a lot of patients may not have the same level of access as you go down the line of therapy. But overall, I mean, we see this consistently, whether you target RAF, RAS, or MSI disease, that your whole curve shifts more significantly versus standard of care. So we're definitely changing biology. Probably has to do with the microenvironment. You're changing essentially the behavior of the tumor at the microenvironment level, perhaps more immune competent, perhaps less aggressive. I mean, there are a lot of hypotheses of the whys, but that's definitely an observation. In terms of pancreas, you do see some of these advantages as well. Most of the experience with pancreas had been primarily in the more refractory setting. You know, we've published the work on adagrasib in pancreas cancer in a small cohort of patients. Some of those patients, you know, ended up, after failing multiple lines of therapy, to two plus years continuously on treatment, so which is, you know, pretty impressive. With the pan-RAS inhibitors, you know, we know of data in the first line that looks more solid than even chemotherapy. So again, as we move those to earlier lines of therapy, you're starting to see bigger and bigger differences in terms of outcomes, you know, even without chemotherapy. So the question is, you know, similar to BRAF inhibitors, do we need that, you know, chemotherapy punch alongside with the RAS inhibitor likely, especially in more aggressive disease?